My name is Dana Goldman. I'm the director of the USC Schaefer Center for Health Policy and Economics. Also the interim dean of our policy school, which is why you see the sad face right now. I want to thank you for joining us on behalf of the USC Brookings Schaefer Initiative for Health Policy and USC Behavioral Science and Wellbeing Policy Initiative for this expert discussion on encouraging vaccine adoption. All of this presumes, of course, that there's adequate supply, but I think we might get into that as well. I'm really pleased to be joined by some outstanding panelists. They're going to each give brief remarks to introduce some topics, and then we'll have some discussion and Q&A. I want to remind the audience members that they can submit questions at any time using the Q&A feature. So let me begin by introducing all the experts. First, we have Wendy Bruin de Bruin. She's co-director of the Behavioral Sciences program at the USC Schaefer Center. She's co-PI of the USC Behavioral Science and Wellbeing Policy Initiative. She's a provost professor of public policy, psychology, and behavioral science in the USC Price School of Public Policy. And her research really aims to understand and inform how people make healthcare decisions, which is obviously relevant here. And since March, she's been conducting national surveys on US residents' COVID-19 risk perceptions and the behaviors they're taking to protect themselves and others. Also like to introduce Rich Besser. He's the president and CEO of the Robert Wood Johnson Foundation. He's the former acting director of the Centers for Disease Control and Prevention. And I can tell you that things were working much better when he was there. And he was ABC News' former chief health and medical editor. He's really a leading voice nationally on the importance of health equity, advocating for racial justice and full inclusion of people with disabilities, and a COVID-19 response and recovery that prioritizes those most impacted. We're also joined by Allison Buttenheim. She's an associate professor of nursing and health policy. She holds the Silverstein Chair of Global and Women's Health. She's scientific director of the Center for Health Incentives and Behavioral Economics at the University of Pennsylvania, which has been one of the leading behavioral research institutes in the country. She's a leading expert in the application of behavioral economics to infectious disease prevention. Her research agenda has focused on vaccine acceptance and vaccine exemption policy in the US, zoonotic disease prevention in Peru, and HIV prevention in South Africa. She served on the National Academy's panel on the equitable allocation of the coronavirus vaccine in 2020. And then finally, but not least, is Jason Doctor, who's Director of Health Informatics at the Schaefer Center. He's co-director of the Behavioral Science program at the Schaefer Center with Wendy. He's co-PI of the Behavioral Science and Wellbeing Policy Initiative. He's also the Norman Topping Chair in Medicine and Public Policy at the USC Price School of Public Policy. He's been one of the leaders in looking at decision-making in healthcare and behavioral economics and the use of choice architecture to affect policy in health and medicine. So a really well-credentialed panel. I'm looking forward to seeing if they live up to that now. So which of you with that introduction is going to start? I think it's Wendy.
Thank you, Dana, for having me part of the panel. Let me share my slides. So before I share insights on behavioral science insights on promoting vaccine adoption, I wanted to show these data from the Understanding America study, which is a nationally representative survey that we've been running at USC since March of 2020. And since April, we've been asking people in the US how likely they are to get the coronavirus vaccine if it's available. And in March, 83% of our participants said that they would get it, but that has now declined. The last survey was in December. They do the survey every 2 weeks. It's declined to 63%. So that suggests that we really need to get in place a good vaccine allocation and communication strategy to encourage people to get vaccinated. So here are some behavioral insights for promoting vaccine adoption. So first is to make vaccine communications understandable. In a study that I conducted in 2008 with Julie Downs at Carnegie Mellon, we found that parents who were deciding to vaccinate their children for against childhood diseases, they would go online and use simple words to look for information about vaccines. So they used, for example, shots instead of vaccination, and that would land them on anti-vaccine websites instead of the CDC websites. And so if we want to communicate to people about vaccines, we need to use words that will help them find our information and to make that information understandable. A second important point is that it's important to make it easy for people to get vaccinated. So a study conducted in 2016 showed that people were more likely to get a flu shot if they were invited to get a flu shot combined with a scheduled appointment for getting a flu shot. And they would be more likely to get a flu shot than if there was a scheduled appointment than if they were just asked to call and make an appointment. And even people who couldn't make the scheduled appointment would often call and reschedule and then get vaccinated anyway. So default appointments make vaccination easier for people. Some countries are also rolling out community vaccination centers so that people can walk up and get vaccinated, and that might be useful as well. A third important point is to make vaccinations the norm. So a study that I published in 2019 suggested that people who perceive that more of their friends and family have gotten the flu shot are more likely to get the flu shot themselves, even if they didn't do so in the past. And so that suggests that social norms are important. People look what others are doing. And so it's important to make it more visible what others are doing. So if people have gotten vaccinated, you might ask them to talk to their friends and family about it, to post about it on social media. We might even give people maybe like stickers that say that they can wear that say, I got vaccinated, just like that. I voted stickers. It's also important to make vaccinations, the allocation strategy, fair and transparent. So this is a study that I'm working on with you, Dana, as you know, as well as Alona Oknaku, who is a marketing professor at the University of Leeds. And marketing research suggests that if people are waiting for a product that's on sale, but they don't get selected for that sale, then they may no longer want that product and even act out against the company. This may also happen with vaccinations, especially if people feel that it's unfair if certain others get vaccinated before them. So, and people would like healthcare workers and people at risk to be vaccinated first. Then overall, it's important to address people's specific concerns about the COVID-19 vaccine. To find out what those concerns are, we can do surveys on, for example, the Understanding America study, and then follow behavioral insight suggestions that are published in, for example, the recently produced COVID-19 vaccine communication handbook that is available for free online, and I'm showing the link here. And also, for example, there's a study by Ilan Fisher and colleagues in the Royal Society Open Societies Journal that provides behavioral insights for promoting vaccines, in addition to what I've discussed today. Thank you very much.
Thanks, Wendy. I think Rich, you're up next.
Thanks very much. First, I want to thank you for hosting this important forum on a critically important topic. I know for myself, and I think for most on this seminar, it's hard to not have our thoughts be focused in Washington, where our democracy is under unprecedented attack. But we need to remember that the virus is nonpartisan. It doesn't care what's happening in Washington. And each day there are hundreds of thousands of people who are getting infected and thousands who are dying. When I think about this pandemic and what's going on around the country, it's clear that every community is being being impacted, but not each community to the same extent. Black Americans, Latino Americans, Native Americans have been infected, hospitalized, and are dying at rates that far surpass their percentage of the population. And so as we think about the need for vaccination and who to prioritize around vaccination, it's critically important we think about those that are impacted the most. And so, when I look at the process that we've been undergoing, the process of vaccine development, approval by the Food and Drug Administration, and then the advisory groups to the CDC, the Advisory Committee on Immunization Practices, determining what groups should be vaccinated first, it's clear that they were thinking about how to have the most impact. And so in the first groups, prioritizing those in long-term care facilities because that's where you see the highest rate of mortality, and those in the healthcare system because of the need to keep the healthcare system going. It, in fact, has an impact in terms of issues of equity because there is an overrepresentation in the healthcare system of people of color who have been hit the hardest by the pandemic. In addition to being the head of the nation's largest philanthropy focused on health and an epidemiologist, I'm a general pediatrician. And so when I think about issues of vaccine hesitancy and how to encourage vaccine use, I think back to my early days as a general pediatrician. I still volunteer as a pediatrician. But in those early days, when I had just finished my training, I knew that there was nothing that I did as a pediatrician that had more impact on a child's health than ensuring that child was vaccinated fully and on time. And I remember a parent coming to see me, or a prospective parent. It was a pregnant couple, and they said, we'd like you to be our pediatrician, but we want you to know that we don't believe in vaccination. And what I said was, well, I think you need to find a different pediatrician. I felt that strongly about vaccination, but over time, I think with a little different perspective and maybe a few more years in the job, I changed my tack and I accepted patients who initially said that they did not want to vaccinate their children, accepted those families. And what I tried to do was, over time, through development of a relationship of trust, help them move forward, understand where they were coming from in terms of their concerns, and work to address those concerns. And I think through doing that, I was able to have a broader impact by helping children get vaccinated who otherwise wouldn't. And that informs how I think about where we are now as a nation. These vaccines that are coming forward, it's incredible. It gives me hope for this year. It gives me hope in terms of light at the end of the tunnel. But I also have to recognize that these vaccines were developed faster than we've ever developed a vaccine in our history. And with that, some people are concerned about safety, given that the safety data for approval was only 2 months worth. I watched the hearings, I watched the advisory committee, I reviewed the data, and I feel comfortable that these vaccines are safe and effective. And when my turn comes, I want to get vaccinated as soon as possible. But I also recognize that my sense of risk is not everyone's sense of risk. And it's important to be respectful of people who have concerns, who want to see more data. I expect that over time, we now have millions of people who've received the vaccine. And over time, as more and more people know people who've been vaccinated, and recognize what's happened to them in terms of their level of now protection, their level of comfort in terms of their lives, more people are going to want these vaccines, and that will be a good thing. Trust is a critical part of this, and we saw this past year trust in science, trust in our public health system impacted in very negative ways due to the political interference of this administration. And it's going to take a while to recover from that. I was very pleased to see FDA move forward in their normal approach in terms of reviewing these vaccines for approval, for emergency authorization. And that was a really good thing. But it will take time to overcome the interference that we saw. And my hope is, with a new administration, with new faces, with an administration that vows right now to lead with science, to put science out front, to have politicians lead with science-driven policy, that it will go far to try and address some of these concerns. The other critical piece is that when you look at the groups that are at highest risk, you have to think about who are the trusted voices for those communities. Black America has for a long time been subjected to discriminatory care in our healthcare system, experimentation by our healthcare and our public health system. And so we have to acknowledge that, recognize that, and reach to those voices that are respected and trusted in each community to try and deliver messages that will resonate. Thank you.
Thank you, Rich. And that's a great segue to Allison.
Thanks, Dana, and thanks for putting this session together. I think we've structured this well because I'm going to be, I think, sort of braiding together some of what we heard from Wendy and from Rich. I've actually been a vaccine acceptance researcher longer than I've been a behavioral scientist and applied behavioral scientist. And one of the things I think is really vital in this effort is that we bring a lot of disciplines to the table to encourage adoption and acceptance. We need policymakers, we need designers, we need anthropologists, in addition to psychologists and economists and behavioral economists and public health folks. And so my orientation is really from that kind of multidisciplinary table that I'd like to convene for this. I've been having a lot of conversations with various entities, health systems, cities and states, which are our jurisdictions for vaccine distribution and delivery, insurance companies, community-based organizations. And I think there's a lot of urgency right now to start doing stuff, to start getting interventions designed and stood up and hopefully evaluated to ensure that there's broad acceptance. And that's true for phase 1A for our healthcare workers, as well as when we move down to 1B. And so I've been trying to kind of organize my thoughts about interventions very much along the lines of what Wendy was talking about in terms of behavioral science, and I'm guessing what we'll hear from Jason in terms of nudges, but with the frame of reaching vulnerable people, reaching disadvantaged populations, and trying to rebuild instead of continuing to fray the trust. And so the organizing framework, kind of work in progress right now, has three parts. It's going to sound a little hokey, but I think about sort of the journey, I think about connection, I think about delight. And another way to think about that is sort of the how, the why, and the wow of encouraging vaccine adoption. With the journey, from a marketing perspective, we are really moving people from, hearing about this vaccine and some state of motivation through getting that first dose and that second dose. And that journey is going to look really different for different people. It's going to look different for different people based on their priority stage, and it's going to look different for people based on where they are for motivation. And I think we really need to bring sort of data tools, mHealth, the digital health, eHealth, and just some sort of basics of behavioral science and psychology to help rapidly figure out where people are and get them on the right journey. And that can be stuff like making sure it's really easy to get an appointment. You know where you go, when you're eligible, but also learning from people if they need more support, more information, more conversations to be had, and that really sets us up for sort of meeting people where they are. So for a health system, for example, right now at Penn Medicine, we're thinking about different ways to structure the emails that are going out to different tranches of healthcare workers to make sure, again, that it's not just sort of click on this link to make an appointment, but can we help you through that email journey, make sure you get to your vaccine appointment, or make sure you're able to tell us, if you're not ready yet. The connection piece, I think, really builds on what Rich talked about. We know that there are lots of forms of vaccine hesitancy, and some of them are very rooted in decades, if not centuries, of medical exploitation and mistreatment. And I think we need to be really savvy about asking questions of people to find out what they need. That might be a conversation with a trusted peer. There's been lots of offers, for example, within Penn Medicine for people to serve as vaccine ambassadors or champions or just sort of peer buddies within their departments. And that often works well if it's within the same sort of occupational group. So, if our security team or our environmental services team is having some reluctance or hesitancy, who can they talk to in their department? But that also means things like doing a really good job on social media of promoting the selfies and the stories, and making sure we're doing that in a savvy way, and making those resources like Mythbuster sheets and things like that readily accessible and tailored to audiences. The last piece around delight, and it turns out there's a whole science of delight. The technical definition is, exceeding your customers' expectations in ways that are surprising. And, I think there's been kind of a grim, teeth gritted aspect to this endeavor, which is, a once in a lifetime effort for all of us to sort of get this vaccine out. And it's understandable that we're all kind of like head down and we're a little bit anxious and we're nervous about the hesitancy and about addressing that in an appropriate and with appropriate humility. But I do think there's an enormous opportunity to make this fun and exciting, take advantage of the fact that this vaccine development process has been sort of extraordinary. And in our interventions to really think about how we can delight people. And whether that's keeping lists of folks who have said, if you've got doses left at the end of the day, come find me, I'll be there in 5 minutes, and they get their dose earlier than they thought. Making, fun competitions, the stickers, we have great ideas for like 2-part bracelets that you get. Just really infusing this with a sense of delight that really matches the extraordinary moment where we are. So thinking about sort of interventions and evaluations of all of those, and look forward to speaking as a group later.
Right, the sense of delight like I got watching the new president get certified yesterday, and then suddenly the Capitol got stormed. But anyway, we'll come back to Jason, you're next.
Sure, thank you, Dana. So I'm really happy to be here, and I really enjoyed listening to Rich and Allison and Wendy talk about vaccines and uptake, and particularly the first slide Wendy showed about how people's preferences for vaccine or hesitancy level can change. Rich's ideas about being a clinician and his personal stories, which is what I'd like to also address today. And then Allison's idea about how to move people along this journey. The way that I'm viewing this right now is that we have a large group of people who will probably take the vaccine willingly, and they're excited about doing so. That number will fluctuate depending on all sorts of information in the media, social media, the mainstream media, et cetera, by a small degree, probably plus or minus 10%. Then there will be a group of people who are hesitant to take the vaccine regardless of those things. And some of those people will be, quote, hardliners who it'd be very difficult to change their behavior. This would be, for example, the anti-vax movement folks. But there will also be a large group of people within that set of people that will be, their preferences will be malleable. And I believe that clinicians are well positioned to help lead vaccine encouragements for that group. And I think that group in particular will help get us over the hump that we need for a type of quote herd immunity, the good kind of herd immunity through vaccines and not through disease. I just wanted to point out some things that have been sort of implied in the prior talks. One is that if you talk about vaccine hesitancy, you're really talking about a diverse, different groups of people with different reasons for being vaccine hesitant. 42% of Republicans are hesitant to take the coronavirus vaccine. Several of the previous presenters have talked about how there's a lack of trust due to exploitation amongst African Americans with regard to the healthcare system, and the African American community is highly vaccine hesitant. It's sort of surprising that healthcare workers and essential workers who are at great risk are also somewhat vaccine hesitant. And I think what's interesting about this is that what it says is that we can't have one singular message that will appeal to all of these groups. And really, clinicians will need to tailor messages and tailor the interventions. And it may involve, for example, with the African American community, encouraging more African American doctors to talk to African American patients about their vaccine hesitancy. Clinicians have had a really big effect in prior studies on hesitancy. So just scheduling an automatic appointment for a person is more likely to result in a flu vaccine for folks. There's been clinician-led announcements and prevention messaging, and really putting the pressure on the same day of a visit to say you really need a vaccine has a big effect. It also turns out that clinicians can impede vaccination. So if your clinic doesn't know that your vaccine status, then it just sort of falls to the wayside, and you end up talking about other things during the visit and addressing other problems. Also, by appeasing concerns about vaccines, can signal that vaccines may be harmful. So they're saying like, well, we'll just do your vaccine later, delaying vaccine regimens. Another thing people may not know is that there are initiatives with the federal government, federal incentives and quality metrics for performance on vaccines. And there's also health information exchanges that connect state immunization registries with electronic health records. I would like to see those bolstered for the COVID-19 pandemic so that we can really know when someone is at a doctor's visit whether or not they've had the vaccine or not. And I just want to mention briefly, I want to mention a pilot study that we did in Kansas with the HPV vaccine that's currently under review for publication. And we use behavioral nudges. And one thing that's interesting about HPV is that it's entangled in the culture war. So it's transmitted sexually, so it's a difficult conversation with parents, or can be a difficult conversation with parents. It has some of the same features as COVID-19 that can be politically motivated for your hesitancy. Also in Kansas, it's got the third lowest vaccination rate of any of US states. So we conducted a pilot study where we gave clinicians feedback and parent satisfaction data about visits that involve vaccine discussions. We had clinicians commit publicly to try to get their patients vaccinated, and those posters were visible to patients in the exam room. And we talked about communication and framing around the vaccine and ways in which it may become more appealing. We also bundled the vaccine with other vaccines so that it was just part of a group and not called out as particularly problematic. And this was a pilot study. I don't want to get into the effects. We did see improvements, but it's unclear whether that was due to displaced vaccines, and we really need to do a randomized trial. What was interesting is that parent satisfaction was extremely high, even among a largely vaccine hesitant group after these visits. And there were no differences in satisfaction for the visit for people who got vaccines that day and for refusals. And the biggest effect for people getting vaccinated was clinician awareness of vaccine status. So I think, just to sum up, physicians' vaccine discussions are appreciated by patients, even when they're difficult or politically charged. They don't seem to mind them. Clinicians need to know their patient's vaccine status. We need to do more to connect electronic health records with state registries. We have that capability. And even though hesitant groups have homophily with each other, they're very heterogeneous as separate groups. So we need to consider tailored messages for them. So that's pretty much all I had. Thank you so much.
Thank you, Jason. So now if we could bring all the panelists back, I'd like to have some discussion. Thank you all. I want to get to some really difficult questions here quickly and the challenges we face. So you've all talked about vaccine hesitancy. On the other hand, we know that this is a highly infectious disease, and getting as many people vaccinated as quickly as possible is going to limit the amount of morbidity and death associated with this. So as a strategy, does it make sense to focus on the people who want to get in line and get this shot and then get it to them as quickly as possible? Or should we be saying, you know, in these hesitant populations, some of which it's political ideology, some of it's race, you know, we're going to have to we'll just wait and see. So I'd like someone to talk about how we prioritize expediency against equity.
That's a great question. And I would be very concerned about moving away from a system that lays out clear priorities to groups and works to overcome the barriers to that. That's not to say that we should allow any vaccines to be wasted and thrown away. I think there are ways to target that. But if we go to a system where those who want it get it first, we're going to play into the same two-tiered or multi-tiered system we currently have, a system that is just rife with structural racism. And when you look at those who are most at risk here, those who are essential workers, those who are frontline workers, many who are not getting the protections they need, the vast majority lack sick time, lack personal time off. So, you know, many states haven't been able to set up the systems yet that work to meet people's needs. They work around clinic needs, they work around public health department needs. The resources haven't been there to staff clinics 24/7 or to make it possible, make it as easy as possible for those who want to get vaccinated to get vaccinated. So I'm really worried about that, and it would ensure that those with money, those with social connections, are most likely to get vaccinated quickly.
So I want to, the economist in me can't help but asking you this follow-up question, which is, suppose what part of the problem is we completely underfunded distribution at the expense of R&D. Suppose we had said, we're going to auction off 1 million doses, raise $10 billion so that we can use that money to set up vaccination distribution in grocery stores, in Amazon warehouses, and not in healthcare systems where actually the groups you're talking about have traditionally not have access, but actually bringing the vaccine to the communities you're talking about. In some ways, that would seem to me a more efficient way to serve them.
Well, I would agree with that if we didn't have federal resources to make this happen.
Yeah.
But to say you have to go to wealthy people to fund this,
sure.
You know, it's a false. It's a false problem. Thankfully, I was an economics major, so I can spot some of that.
I will say Mark Zuckerberg just named San Francisco General Hospital. So, okay. But Allison,
Dana, you know, Richard,
solution.
Yeah. I mean, Richard Thaler pitched that idea, the auction idea in the New York Times in December. And I definitely don't see that as an either or. There are going to be, and I will say in Philly, this is, you know, the planning for this is underway to have, you know, vaccine delivery literally meet people where they are. There's obviously some cold chain challenges and logistics with the freezers and the ultra low cold chain. But that's going to happen. There's going to be efforts to get people, you know, vaccinated at church. You know, you think about stroll to the polls. We need like stroll to your shot after church. And where people are already going there, you know, if they're picking up food at a food distribution site, let's vaccinate there. If they're, you know, picking up their WIC coupons, you know, let's vaccinate them there. So I don't think we need the auction to make that happen.
I see. Well, what Bob Kocher and I wrote was you should get a shot with a shot, and we should do it at bars. But maybe that's a
Philly special. Philly special. Beer and a shot. Yep.
Distributing the vaccine where people are, I think, is very important. And then people will also see their peers getting vaccinated, which is an effective way of overcoming trust issues. Because if they see that people like them and people in their community and their friends and family are getting vaccinated, then they trust their friends and family's decisions more than perhaps some, you know, politician.
Right.
Who's not like them.
The faster we can roll these out in these communities and these other areas, the better it'll be. And I just want to point out something Allison said, which was, a waiting list for extra shots. People don't show up. There's an expiration date on these things. It does make sense to make sure, I think the reality is in some cases, these are not going to get used and people don't like to share that. Jason, I wanted to give you a chance to jump into the.
Yeah, I was just going to say that, one thing about Richard Thaler's argument is that it's premised on this idea that wealthy people are going to cheat the system. And he's very explicit about that. And so this is his way of sort of accumulating the money from that to use for a good cause. And, maybe there is some truth to that. It depends how things end up turning out with distribution.
So I want to come back to something, Rich, you said in your talk about the politicization of this process. And it's been very unfortunate. Obviously, public health is an area that, in some sense, it doesn't have an ideology. But the thing that we saw here was there was a real tension between health and economic crisis, and people come. And that's differential across these groups. And so those of us like myself who are fortunate enough can keep doing their work from home in relative safety. But there are a lot of people, if they want to continue to make a living, they're going to have to go out there and take risks on a daily basis. How do we, is the fact that this was tied to some fundamental economics and that some groups are living on the edge, is that a reason for the politics entered into this, or do you see it as just a consequence of who we had as president?
I don't see that as a consequence of politics. I think I see that more as a consequence of long-term policy failure, which is different and spans across many administrations, but. The fact that we don't have universal health care, that low-income workers lack sick leave, family medical leave, unemployment insurance, that tens of millions of people are living on the edge of eviction and foreclosure, and 20% of children live in hunger. This is policy failures over generations. And when you look at the countries that have done the best during this pandemic, the level of social supports are much greater, and they ensure that regardless of your income, regardless of your race, regardless of your occupation, if you think you've been exposed or have been exposed, you have the supports necessary to be able to isolate or quarantine safely. But in America, we're seeing millions and millions of people who are forced to make a decision between staying home to keep themselves and those around them safe, or going to work so they can put food on the table and pay the rent. The politicization came about by this administration not wanting to accept the reality of this pandemic and deciding that public health would be the punching bag. And undermining the credibility of CDC, sidelining and marginalizing CDC, the world's leading public health agency. And with that, you ensure that every recommendation that comes down from CDC will be accepted and followed by no more than half the population, that half that rejects the politics of the current administration. And we know that viruses need a much higher than 50% compliance with control strategies if you want to do anything to reduce spread.
So one of the collateral consequences of this has been an erosion of trust in some of our institutions. And Wendy, you've made the point that trust is important, and who do people trust here? Is Anthony Fauci the national spokesperson, or who should we be looking toward to solve this dilemma?
So for information about vaccinations in general, people tend to trust their primary care physician the most. So Anthony Fauci might be the face of the healthcare providers for people. I want to add something. I've been teaching risk communication for many years, and one of the first principles of risk communication is that you have to make sure that your messages are consistent. And I always thought that it was so obvious to teach that, and everybody in my class would always nod when I say that. But now we see that apparently it's not that easy to have consistent messages. And even in countries where the politicians would agree with the health messages and repeat the same messages, there's some challenges with a pandemic when you're still learning new information. Your message is not going to be consistent because you may have to update and change what you've said before. But it's especially challenging when politicians make this a political issue and disagree with each other about how important it is, and give people different suggestions on what to do and whether to wear masks or not. And then you get people not being sure whether it's a good idea to implement those behaviors. So consistent messages about the vaccine will be really important, in addition to everything else that has been suggested today.
I think we really lost control over the conversation too about, the false dichotomy of either the economy can be open or we can tackle the virus. And, we could have opened the economy months ago if we had done a better job with control. And we totally lost control of that message.
Yeah, actually, just a personal note, if we'd done a better job on testing
Sure.
as well, that was a real failure. We did well developing a vaccine. So coming back to these behavioral incentives, though, Allison and Jason, you have been pioneers in a field where people say you should just pay people to do good things. There's one option is to make a vaccine mandatory. I'm going to put that on the table for the whole group. But should we be, and now I'm getting to the Q&A, and Murray Jacobson is asking, should we be paying people to take the vaccine, and should we pay 50% more to Republicans? That's a joke, by the way, that part.
One concern about paying people, especially paying everyone, is that it may send the wrong signal. It could send a signal that this could be harmful, and so we're going to pay you. It's not clear to me that we really need to pay people. There are probably other ways that we can go about doing this. I don't know, Allison, if you have other thoughts.
Harold Schmidt and I just had an op-ed in the Philly Inquirer yesterday about this, arguing the no incentive side. And Emily Largent from Chibe and Penn had a nice JAMA viewpoint yesterday as well. I think laying out really strong arguments for why incentives are often great, and for this particular behavior, probably not the right tool in the toolkit.
So let me ask you then, maybe I'll go to Rich for this one. We argued that health insurance, it should be mandatory because we're all in this together. With vaccines, we're all in this together. We need to get to herd immunity. Should vaccination be mandatory?
I think that before you can even think about addressing that, there has to be enough supply of vaccines so that everyone who wants it can get it. And then I think that there could be situations in which, yes, you should make vaccination mandatory. I mean, we make it mandatory for children to be in schools. You can make a case for anyone who wants to get on an airplane to be vaccinated. But I think that I would not be comfortable with a broad-based mandate that everyone in America must get vaccinated. I don't think that there has been a long enough history with these vaccines. I think that it will be. We're not going to. We would never have a day where people are knocking down doors to and holding people down to put a needle in. And so I think we're going to get much further by really understanding people's hesitancy, their concerns, looking at some of the behavioral interventions that the panelists have all been laying out, and making it as easy as possible for people to get vaccinated. So no, I'm not. only special circumstances would I see that as the way to go.
And Zika is talking about large segments of the population. Zika Manual, of course, doesn't think anyone over age 75 should get health care generally. But I think a lot of people saw in the COVID crisis, that was pre-COVID, by the way. I think a lot of people saw during this crisis that, and a lot of countries are choosing to vaccinate older Americans who are clearly the age mortality profile for this is quite steep. And I believe one of the questions says that Florida has opened vaccination to people over age 65, and it's resulting in long lines. So is this good for motivation? And Wendy, you've done work on this as well, so I'll start with you. Is it good for motivation to say older people can get it and then understand that the queues may be a problem, or how should we deal with this?
I think that making it available to people over 65 might be a good idea, but then managing those queues, because those queues make it harder for people to get vaccinated. So maybe scheduling people in particular slots, or having multiple distribution centers so that people can get vaccinated. And if you don't have enough vaccines available for those groups, then perhaps do not yet open it up to those groups and work with a waiting list instead.
So do you think we should let the Pennsylvania Election Commission organize this, or should we? California did a good job. Florida actually did quite a good job in the last election, so they have their act together. So maybe we should let Florida do this.
Yeah,
no, they've been scheduling it using Eventbrite. Like, that's how you sign up for your vaccine. So,
and the scheduling is a brilliant idea.
Yeah.
Okay. Some other questions. This is the theme of some of the questions, which are, do we tell people about the rare but possible risks? And Rich, this gets at maybe the ultimate adverse consequence would be if we targeted the communities that you spoke about, and then it turned out that there were long-term side effects we didn't know about from this vaccine. That would really set us back in public health, I think, quite a bit. How should we tell people about the risks, and should we worry about them, and how does that affect the strategy?
Well, I think it's pretty clear from the work of Kahneman and others that humans are really terrible at weighing risk, and we tend to truly overvalue the risk of anything that's done intentionally. So people would feel much comfortable with the risk of getting and dying from getting COVID and dying from COVID than they would a small risk of anaphylaxis or bad reaction to a vaccine. So it is really challenging, and thinking about how you present it to people is really important. But I think from a trust perspective, for me, transparency rules. And, it's one of the things that always drove me nuts at CDC, and still drives me nuts at CDC, is the lack of transparency each year around the expected reduction in flu transmission from the flu vaccine. Getting the flu vaccine is the best thing you can do to reduce your risk of flu, except what may be appearing now is everyone in society staying indoors and wearing masks. But the flu vaccine is one of the best interventions you can do. But in some years, the level of protection for the elderly is zero. It's zero. And we have to be honest about that, and trust that people can handle information. And so I think you build up trust points by sharing information that isn't necessarily always so good. So I saw there was a question about CDC having a press conference about 20 cases of anaphylaxis to the vaccine. That's really important information for people to have. And it has to be couched in the right way and framed in the right way so people can understand it, that this is a reaction that the healthcare system knows how to manage. There's a drug that you can get that reverses it very quickly. And thankfully, that means that even people who have a history of severe allergic reactions can get the vaccine as long as it's done in a controlled setting in a healthcare place where that can be managed. And thankfully, 99.999% of people who get it won't have that reaction. So there's ways of framing it, but hiding the information and telling people not to worry about that is not the way to go. There's a way of treating people with respect, and part of that is recognizing that different people will process risk in a different way, and it may have to do with lived experience and why they don't have trust in systems that another person may have trust in. But you get into real trouble when you say, "Oh, I don't think people can handle the truth."
So, final question, and then I'm going to give everyone an opportunity for last minute comments, which is that in a couple months, maybe 3 or 4 months, we're going to have a lot of people who have had 2 doses, some people who've had 1 dose. A lot of them, I think, will feel rather powerful. And we have to worry about their behavior. We don't know about the transmissibility. Certainly, if it ends up on my mask, it's possible then someone touches it, there's still a risk of infection. Are we going to be having another webinar in 3 months about how to get people who've been vaccinated to behave? Jason?
We'll always have webinars about how to get people to behave. I think it's really important for people who are vaccinated to still, abide by the protocols of wearing a mask. We don't know, like you mentioned, we don't know about transmissibility. One way to think about it is like a security guard. We don't know where the security guard is. Is it at our nose or is it inside our body? And there might be the ability of the virus to transmit even though we don't become infected. So I hope.
But Jason, I mean, we've had college outbreaks on college campuses. Kids have been stuck indoors. They would love to get a vaccine and go party. I think we have to recognize that. My question is there anything we can do on the behavioral side to discourage that type of behavior, which will put lives at risk? Wendy,
well, I think we can. The most we can do is what we're doing now, which is restrict activities unless people wear masks. So you can't go inside a grocery store. Now it will become more difficult if the country opens up further and people are going back to the movies and things like that.
Well, I just want to ask Allison, though, if we asked 30-year-olds to give us their credit card when they got their shot and say that we're going to charge your credit card $100 if we find out you were in a party without a mask.
I think they'd be willing to pay that $100 to go to a party.
Well, then we can put the money towards, something good. But
I was hoping you were going to say, we'll give you the $100 back when you come for your second dose, because that's a whole nother behavior that I'm worried about, is making sure people do serious completion. But I think there's also some mental model stuff. I mean, right now, people are imagining that the vaccine is like the end, like the light at the end of the tunnel in the end. Really, it's just another one of those layers of Swiss cheese in that Swiss cheese figure, right? It's just another protection that for a while still we're going to have to just add to our NPIs. So that kind of frame, I think, can be helpful.
I think it's also important to keep track of how, once people get vaccinated, to keep track of how common it is that people who are vaccinated pass it along, and so that we have the data on this, and so we know what behaviors are still needed and what behaviors are perhaps relatively less risky and okay, because people are really excited about going back to parties or small parties perhaps. And so if we know that people can do some things relatively safely, then I think that would be very important information.
I also think that's one argument for vaccinating the elderly first, because they're at greatest risk, obviously after healthcare workers. But if that's done, then college kids going back to parties can't go visit their grandmother and wreak havoc. So I think that's important.
Okay, we're running out of time, so I wanted to give all of you a round of last minute thoughts. This has been a really fulsome discussion, and I wish policymakers would just listen to the four of you and we'd be all set. But we'll start with you, Rich.
Well, thanks for this session. It's really been fun. The one thing I want to add is that it's we've had such a poor investment in our public health system over many decades that we lack a lot of the systems that would make vaccination tracking, vaccination follow-up more easy. The other piece of it that we lack are good systems to be able to look at vaccination by race, by ethnicity, by geographic location to make sure that as we go forward, we are applying principles of equity and racial equity in particular. So I worry that the lack of attention to that will result in us moving forward without having visibility and likely not having the type of equity impact we would like to have. Because when you see issues, problems, when the data can point those out, you can then direct additional resources to try and understand what's going on and address it. But if you can't even see what's going on, that's a real problem.
Thank you. Wendy?
I think we've been focusing a lot on communication strategies today, but I'm currently concerned about how are we going to have enough vaccines and get it to people as soon as possible in their communities, and that would be really important. And then once that happens, when working with the communities, I think it will be, if they work with the communities in making that happen, then it will be easier to develop communication strategies that are targeted to those communities as well. So that goes hand in hand.
So you're saying we should have been building RVs that go into communities and with the vaccine.
Yeah, and we saw that this was coming, right? So we could have been planning for this all along. And I realize you shouldn't complain about what you can't fix now, but we can still do these things now because the vaccine is still being rolled out. And we should think of ways of getting it to people as easily as possible.
And then we could have had the slogan, hop on the vaccine bus. But sorry, Jason?
Yeah, I think the only thing I'd like to add is that there are real natural incentives for healthcare systems to track and promote and encourage vaccines among their patient panels. That healthcare systems are hemorrhaging money right now. Outpatient are moving to telemedicine because of they can't have people in the office. Most of the inpatient care right now are bed days. There's no procedures. They're cutting down on surgeries, which help pay the bills. So I think there are natural incentives really for healthcare systems to take a lead here, and I hope that they do.
Thank you. Allison, last word.
I think my last word is, I think over the course of our hour-long conversation, we probably pitched 25 or 30 different intervention ideas to try to get this to happen. And we really need to build in a very light touch, nimble, not, it doesn't need to take 3 years to run a RCT, but we need to do evaluation along the way here so we can learn. And we need to learn in March so that we can do different stuff in April. I do fear getting to the end of 21 or 22 and not knowing what worked, because this is not the last pandemic, sadly.
And if I can, I'll just, since we have 1 minute, I'll put on my policy hat and just say, I think you've all kind of hit on the fact that our public health infrastructure has crumbled. It's eroded over time, as Rich said, over generations. And we now realize how important that is. And I hope that we'll rethink how we invest, not just in the R&D side, but on the actual distribution and the surveillance and the epidemiology of infectious disease. So thank you all very much for your comments. Thank you to the audience for their questions. I apologize to They were excellent questions. Feel free to follow up with the participants. Thank you to the Schaefer Center and the Schaefer Initiative and the Behavioral Science Initiative for their support of this. And take care, everyone.